you are able to hear me well?
Yes, we can hear you well.
Okay, so great. So we'll talk about interstitial lung disease, also referred to as diffuse parenchymal lung disease. This is a session that we missed last time, and the intention is to go through to get opportunity to ensure all the missed sessions are given. If I can get my slides to move here. So this is what we'll go through, a definition of interstitial lung disease, the clinical presentation and evaluation. I put here specifically radiographic features because we rely heavily on radiology to identify these diseases, a little bit on classification, treatment, and prognosis. It's important from the outset to point out that interstitial lung disease is not one disease. That's why we are saying it's a classification of many diseases, actually over 200. We don't have a disease called interstitial lung disease, but this is a classification of a group of diseases that have a peculiar presentation that we will talk about today. So diffuse, which is the other term we use to describe these diseases, is a condition, a presentation that is not limited or localized, which means it's spread out. And usually these is characterized through either radiology or pathology. So when we talk about diffuse or interstitial, we actually mean that we have either looked at a radiological image or we have access to a pathological characterization of the condition. Generally speaking, these are diseases that involve the pulmonary interstitium, which is the space that is intersposed between the air space epithelium, that's the alveolar epithelium, and the vascular endothelium, which is the pulmonary capillary endothelium. And on the pleural, on the visceral pleural surface, the pleural mesothelium. So you're really just talking about that very narrow space in between those epithelia and also the pleural mesothelium. Obviously, the disease is not strictly limited to these structures, so it will also affect the adjoining vascular and airspace structures. So that's really important for you to visualize. So in the form of a schematic, we are talking about, of course, this is the alveolar space with endothelial cell, which is the capillary, and therefore we're talking about this space here, the space between the endothelium and the alveolar epithelium. The components that are affected are as listed. So that space will contain fibroblasts, which of course you know are responsible for collagen formation and various other components of connective tissue. You will have myofibroblasts, pericytes, smooth muscle cells, undifferentiated mesenchymal cells, immune cells, matrix itself, the basement membrane, the epithelia, macrophages, and lymphatic vessels. So when these diseases present, they present because one or more of these components of the interstitium are affected. The primary function of the interstitium, as you know, obviously, number one, is to provide structure to the pulmonary, the lung parenchyma, but also it plays a very important role in terms of gas exchange. So we're referring to this very narrow space here. This will be your capillary here. This is your alveolar on this side. And it is this very narrow space. And you can imagine that this is the space through which gas exchange happens. And therefore, you can begin to imagine what would go wrong if this space for whatever reason is compromised. You would realize that this space, number one, should be kept very, very narrow, very thin. From your physiology, you would know that this distance affects the diffusion of gases, that is CO2 from the blood to the alveoli, to the alveolar space, and oxygen from the alveolar space to the capillary. So you can begin to really imagine, what are some of the things that can go wrong if this interstitium is not functioning optimally. In terms of a histological depiction, you can imagine that this is these are your alveoli, okay, and you on this side you have your mesothelium pleura on that side, and really you're talking about the space that is in between the capillaries and the alveoli. So that's that in the form of a depiction. This is a normal interstitium. I will be showing you depictions of interstitium that has been affected by disease. This is a lower magnification of a reasonably healthy interstitium, consisting of, as you know, the space between the alveoli and the capillaries. It's also important to know that when these conditions occur, they would also affect the adjoining structures. So the bronchioles will be affected. Also, the larger pulmonary vessels will be affected, and that will also play a role in the pathogenesis, the pathophysiology, and the presentation of these conditions. So as I said, this is not one disease, but it's a heterogeneous group of diseases which primarily affect the lung interstitium and the alveoli. And there is involvement of the contiguous bronchial vessels and small airways, as well as the visceral pleura, which, as you know, extends in the form of recesses into the interstitium. Okay, and these diseases, as I've said, there are very many. There are almost 200 or so, and the causes are also diverse. So really, you are just talking about diseases which on histology or on radiology present as a diffuse picture. So you want to think about their causation can be infectious. It can be due to vasculitides, can be due to collagen vascular diseases, various collagen vascular diseases. It can be because of aspiration or hemorrhage. Some are genetic. They can be drug-induced, malignant, They can be due to occupational exposures, or they can be idiopathic. For purposes of this discussion, we will be limiting ourselves to examples of diseases or parenchymal or idiopathic, or diffuse lung disease, which are due to idiopathic causation. But as you can see, really their causation can be very, very diverse. Obviously, as you know from your other sessions, you make a diagnosis of an idiopathic condition by exclusion. So you want to exclude the more common causes of a diffuse picture on radiology or on histology before you start thinking about rarer causes, and also before you start thinking about idiopathic conditions. So how do these diseases come about? We estimate that you have a primary injury which involves the type 1 epithelial and capillary endothelial cells, and these would interfere with the fluid balance function of the interstitium, leading to interstitial edema and accumulation of extracellular fibrin. And then you have a recruitment of inflammatory cells into the interstitium. These cells include the neutrophils, macrophages, lymphocytes, and also activation of type 2 epithelial cells, which replace type 1 cells, leading to extensive fibrosis. So that's in the form of pathogenesis. The initial injury can be is usually diverse. As we said, can be due to occupational exposures, infections, malignancies, etc., etc. So once you have that initial injury, then it sets off a cascade that eventually leads to extensive fibrosis of the interstitium. So you can imagine here you have a section. The one on your left would be the deceased section. You can compare that to the normal lung parenchyma, definitely showing extensive fibrosis, thickening of the interstitium, and a lot of inflammatory infiltrate. All these cells that look more like round, more like lymphocytic infiltration, and you can imagine the kind of consequences that can arise from an interstitium that looks like what you see on your left, compared to the normal depiction on the right. So the hallmark of the pathology that you just saw is really gas exchange abnormalities. Once you have a very thickened interstitium, it means that you have impaired diffusion of oxygen or CO2 across that barrier. And the one gas, the one that is most affected is the diffusion of oxygen, so leading to hypoxemia. You will also have ventilation perfusion defects, and maldistribution and shunts, contributing further to the hypoxemia that you will see. Of course, the interstitium plays a very important role in, both giving the lungs their elastic, property, but also, more importantly, the production of surfactant is also affected. and this will give you increased lung stiffness and reduced compliance that would result in dyspnea, okay, as another important consequence of interstitial lung disease. We've already talked about the classification. You can look at the classification in the form of etiology, so connective tissue diseases like rheumatoid arthritis, SLE, systemic sclerosis. You can have drug-induced pneumotoxic agents like neutrofurantoin, amiodarone, cytotoxic agents, cocaine. Radiation can give you this kind of interstitial pathology. You can have primary unclassified or immune-mediated like sarcoidosis, occupational conditions like silicosis, hypersensitivity pneumonitis, and then idiopathic disorders like IPF, so that's idiopathic pulmonary fibrosis, or NSIP, that's the disease supposed to be P, non-specific interstitial pneumonia or non-specific interstitial fibrosis. So this is a schema of the classification that you are likely to see. So giving conditions that give you an interstitial picture, you can classify them as those that are due to known etiology. So inorganic dust exposures, organic exposures, smoking-related lung disease, those that are related to connective tissue disease, and then those that are due to drugs, or you can have those that are of unknown etiology like Langerhans cells, histiocytosis, the vasculitides, sarcoidosis, and the group that is referred to as idiopathic interstitial pneumonias like IPF, and those that are non-IPF. So this is the general schema, how we look at these diseases. What is important for you is to know that you can have this picture because of a known etiology or because of unknown etiology. Obviously, identifying the underlying cause in the form of known etiology is very important, because then you can target your interventions at the known cause for the picture that you are seeing. Those of an unknown etiology are a little bit more complicated. We shall talk briefly about how you approach these conditions. So these diseases in the form of epidemiology, they are slightly more common in men than women. So what you see there is a prevalence of it 1 in 100,000 and 7 in 100,000 in women. The incidence is also higher in men compared to women, and they appear to be commoner in the older age group compared to younger. So the incidence appears to increase with age. So as you can tell for sure, they are fairly rare conditions. In general practice, you are not likely to see a lot, but if you then are in a respiratory practice, you're likely to see a large proportion of your practice having patients who have these conditions. If you look at the contribution of each of these, those that are due to pulmonary fibrosis are the commonest, and this is really within a respiratory practice. Then that is the contribution of the other etiological causes. So this is really within a specialist respiratory practice. So how do we evaluate patients who present with diffuse parenchymal lung disease? So the first question to ask is this picture consistent with diffuse parenchymal lung disease? That's the first question you want to ask. If yes, then what type is this kind of parenchymal lung disease? Once you have classified, then you want to look at, what is the likely cause, and what are the diseases associated with morbidity, including complications. So the first thing is obviously to start with a good history. You want to, most of these patients are going to present with shortness of breath, usually of gradual onset. They will have cough, often long-standing and usually non-productive. They may or may not have weight loss, may or may not have fever. Presence of fever will point to infection and other immune-mediated parenchymal lung disease. So here when you have fever, you really need to be thinking about tuberculosis, pneumocystis, pneumonia, fungal disease, fungal pneumonia, sarcoidosis, hypersensitivity pneumonitis, connective tissue-related interstitial lung disease, and drug-induced lung disease. So those will be important differentials if you have fever. As we have said, age is important, the gender is also important, and you also want to look at underlying comorbidities, drug history, smoking, comprehensive occupational history, hobbies. For example, do they keep, pets? And obviously we have some of these conditions which are familiar in nature, so a good family history would be very important. Age is important because, as we said, the age distribution of various diseases of this interstitial lung disease differs by age and also gender. So, for instance, tuberous sclerosis and Langerhans cell histiocytosis would be diseases that you will see predominantly in women, and then pneumoconiosis would be diseases that you are likely to see in females. Occupational history is very important. Exposure to various dusts, inorganic dusts, dusts like silica, asbestos, talc, kaolin. People do mining, aluminium, berylliosis, hard metal fibrosis, coal workers, pneumoconiosis, barytosis. So of course, these will depend on where you are practicing. I think in our setup, the things that you need to worry a lot about are silica, exposure to silica. People work in cement manufacturing, work in construction. There's quite a bit of road construction going on. So taking a good history of exposure to dust is very, very important. The duration of the disease is very important. If is the disease acute in onset, which is days to weeks, these would imply things like diffuse alveolar damage, vasculitides, drug-induced, connective tissue diseases. If it is subacute, then you are thinking about things like that's weeks to months, things like sarcoidosis, non-specific interstitial pneumonia, drug-induced disease, and then chronic diseases would generally Chronic presentation will relate more to the fibrotic kind of conditions, as well as a smoking related lung disease. Physical findings, of course, you want to do a good, thorough physical examination, looking out for things like finger clubbing, which is a prominent presentation of idiopathic pulmonary fibrosis. And the other things that you want to look out for is, radiographic features. So a chest X-ray, HRCT, do physiologic testing, so that's pulmonary function testing, exercise testing, and then lung sampling, where you may need to do bronchial alveolar lavage or a lung biopsy. The chest X-ray may actually be normal in 10 to 15% of symptomatic patients, and therefore 30% of patients with bronchiectasis, which also presents with a generalized, a diffuse kind of a picture. And as you can see, up to 6% of patients with emphysema could actually have a normal chest X-ray. So a normal chest X-ray does not exclude a diffuse parenchymal lung condition. The more HRCT is much more sensitive in picking out diffuse parenchymal lung pattern. Physical examination, we've talked about these, wasting, fever, clubbing, tachypnea, crackles, cyanosis, and features consistent with pulmonary hypertension and core pulmonary. So, as we've said, this is a very broad group of diseases. So the investigations would really depend on the suspected underlying etiology. So you want to order your tests based on what you are suspecting to be the underlying condition. So just as a vignette to illustrate what I mean, this is an 80-year-old male, diabetic, hypertensive, who presented, with progressive dyspnea and cough that had lasted 3 years. The cough was brought on by exertion, mostly dry, occasionally productive or clear mucoid sputum, and had no hemoptysis. He'd experienced progressive decline in exercise tolerance. He reported night sweats. However, he had not had any weight loss, and his appetite was normal. Okay, so this is the chest X-ray that was obtained, and really what you see here is a classic example of what we refer to as diffuse. So you can see that there is diffuse disease predominantly affecting the lower and middle lobes. Okay, it's not localized. And if you look carefully, you can see things like honeycombing, and these streaks. And remember, this patient was presenting with a 3-year history, which would imply that you are going to be dealing with a fibrotic presentation. Okay. So when this patient was examined, it was noted to what was noted was significant was grade 3 finger clubbing, saturation at rest, which was 97, which is normal, but which dropped 9 to 92% upon climbing one flight of stairs. And of course, chest examination was remarkable for reduced lung expansion and inspiratory by basal crackles. Okay. This is a lung function that was done, and what you are able to appreciate is really a tiny reduction in both FEV1 and FVC. Usually the FVC and FEV1 are reduced by sort of equal proportions, which means the ratio remains normal. And that's what you are able to appreciate on this spirometry. This is the HRCT, which then shows much more clear the honeycombing fibrosis districts, what we call tram lines, which you are able to appreciate here. So these are airways which are so there's dilatation of the airways because the fibrosis pulls the airways apart. So they appear to be dilated. Okay. So this is in the lower lung fields. You can appreciate these peripheral distribution of the fibrosis, the very prominent honeycombing, and these strips of fibrosis. This is a surgical reconstruction, sagittal reconstruction, where you can appreciate that the changes are predominantly in the lower lobes. And as we said, when you come across this patient, some of the things you're looking at is history of drug use, occupational exposure, systemic disease, smoking, and so on. So these are things we have already covered for the idiopathic interstitial pneumonias, the way we classify them into idiopathic pulmonary fibrosis and other conditions other than idiopathic pulmonary fibrosis. And these would be the important subgroups: desquamative interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, which is actually related to smoking, acute interstitial pneumonia, organizing pneumonia, non-specific interstitial pneumonia, and lymphoid interstitial pneumonia, which is, this one is also related to HIV infection. So I think that is what I have here. Certain we have already seen this picture of what would be qualified as idiopathic pulmonary fibrosis. Usually, the way you decide it is likely to be idiopathic pulmonary fibrosis is that you have subpleural bibasal changes. You have interlobular septal thickening, often with honeycombing, and there is minimal what is referred to as ground glass opacification and traction bronchiectasis. That is where the airways are pulled apart by fibrosis and they appear, dilated, and that's why we call it traction bronchiectasis. On histology, you will see fibroplastic foci. So, for example, what you are able to appreciate there, those are fibroplastic foci, And then there's a temporal and spatial heterogeneity in the way in which the disease presents on histology. This is an example of a non-specific interstitial pneumonitis, and you can appreciate the ground glass opacification, okay? And when you see these prominent ground glass opacification, the patients here will tend to be younger, okay, and the presentation will be cough, fatigue, and weight loss in up to 50% of patients. But this HRCT, what is showing is really this ground glass opacification. This is an example of a respiratory bronchiolitis, interstitial lung disease, and diffuse interstitial pneumonia, which are conditions which are related to smoking. So most of the patients will have a history of smoking. They will be younger, 30 to 40, more common in males. And what you are able to appreciate is centrilobular ground glass nodules, thickening of the central and peripheral airways, and centrilobular emphysema with air trapping. So those are the features that you are able to appreciate here. So this will be the ground glass nodules, very subtle changes, usually peripheral. So this is an example of desquamative interstitial pneumonia, also prominent ground glass opacification. There is the septa are interceptor thickening, and in histology, very prominent macrophages which fill the alveoli. So this is just a summary of how you want to proceed in evaluating these patients. After you have done a HRCT, you are likely to have a picture that is highly suggestive of IPF, or it will be undiagnostic. Then it means you have to go into bronchoalveolar lavage or transbronchial biopsy. If the HRCT suggests occupational, environmental, drug-related, or infection, then you just go ahead and manage that condition. Generally, these diseases are best treated in a specialist center, so you're best advised to refer if you identify interstitial lung disease, particularly of the idiopathic form, those related to connective tissue diseases, anything that is not infectious, you should refer them to a specialist center or specialists to manage them. They are fairly complicated to deal with, and should really not be managed in a general medical setup. Okay, so I think we'll stop at that. The rest of the information we'll give you in your final year when you do your therapeutics sessions. But for now, I'll stop there and invite a couple of questions. So these so gender distribution, I think I've talked about that as we went along, but there's somebody who wants for us to have a repeat of the gender distribution. So for example, here, this is Langerhans cell histiocytosis by age. And as you can see, you know, so that distribution is quite clear. You see it in patients less than 50 years. If you are talking about IPF, the majority of your patients will be sort of above 60, all right? Things like tuberous sclerosis and LAM are conditions you will largely see in females. Pneumoconiosis, you are likely to see them in what? In males. And basically, a lot of the parenchymal lung conditions that are related to occupation, you are more likely to see them in males as compared to females. Okay, what was the other question here? Could you please explain how the finger clubbing comes about in lung disease? No one really knows. What we know is that it's an important feature of lung disease, liver disease, heart disease. How that happens has not been fully defined. Why you see finger clubbing in these conditions. The X-ray review, these are things you will also be covering in your radiology sessions. Get used to attending the sessions and learning how you look at these X-rays. But generally speaking, in diffuse pulmonary disease, what we are saying is that the picture is going to be of a diffuse nature, not localized, usually consisting of these streaky shadows. For purposes of this particular patient that I presented, predominantly affecting the periphery and also the lower lobes. Okay. I think that is it for this session. As I said, this is the interstitial lung disease is really a constellation of many conditions. What is important for you is to be able, number one, to identify a diffuse picture on radiology, look at the likely underlying causes. If the underlying causes are manageable, things like infections, occupational exposures, then deal with those. If they are suggesting of either things related to connective tissue disease and idiopathic nature of the presentation, then these are conditions that you want to get help with, a physician and generally speaking, a pulmonary medicine specialist. Thank you. I think we have finished in good time for you to join the next class, which will be presented by Dr. Eric Mugambi. So I'll join in to introduce you the guest speaker for the next class. Okay, thank you. We'll see you at 12 for the next.